Namaste, म Dr. Amrita Shrestha. As a recall CE Dermatology 2077 को चाहिँ यो past questions मा dermatology चाहिँ discuss गर्न लागिरहेको छु. Starting with first question. The first question is the stratum lucidum of skin is found in options are A. Scalp, B. prepuce, C. palms and soles, D. skin on the face. अब यसको डिस्कसन गर्दाखेरि चाहिँ यो चाहिँ हाम्रो stratum lucidum भनेको चाहिँ हाम्रो स्किनमा चाहिँ सबभन्दा माथि एपिडर्मिस हुन्छ. एपिडर्मिसको चाहिँ 5 वटा लेयर्स हुन्छ. स्ट्राटम मुनि बेसबाट सुरु गर्दाखेरि चाहिँ हाम्रो स्ट्राटम बेसली हुन्छ. त्यसपछि त्यो भन्दा माथि स्ट्राटम स्पाइनोसम, त्यो भन्दा अझै माथि स्ट्राटम ग्रानुलोसम, त्यो भन्दा अझै माथि चाहिँ पाम्स एन्ड सोलमा मात्रै स्ट्राटम ल्युसिडियम हुन्छ, अरुमा चाहिँ हुँदैन. अनि त्यो भन्दा माथि सबभन्दा अप्पर मोस्ट लेयर चाहिँ स्ट्राटम कर्नियम हुन्छ. अब स्ट्राटम ल्युसिडियम के हो त? Is a thin, clear layer of epidermis that is found only in the palms and soles. It is smooth, translucent layer of the epidermis. The skin of the palms and soles are thick, while अब हाम्रो जुन prepuce थियो, face थियो option मा, अनि scalp चाहिँ they are thin. So in those areas, stratum lucidum is not present. And the stratum lucidum is made up of keratinocytes, and they are dead and flattened cells. And these keratinocytes are densely packed with eledin, that is a clear protein rich in lipid. They are derived from keratohyalin, which gives these a transparent appearance, so its name is lucid. And it provides a great barrier to water because our hand and palms and soles are frequently exposed to friction and water and detergent. So to protect our skin from all these chemicals and detergent, it needs to be thick. So it is densely packed structure, and it is found in palms and sole only. Now, second question is, in case of scabies, the drug that can be safely given to pregnant women is, options are A is ivermectin. Ivermectin is oral. And second one is gamma benzene hexachloride. Then third option is permethrin, and fourth option is malathion. So the correct answer here is permethrin. Why permethrin? Because it is given topically. It is given mostly at bedtime, to be applied all over the body, excluding face. So it's only about 2% of the topically applied dose is absorbed systemically. Studies have also shown that when we use this permethrin in the first trimester of pregnancy, it doesn't have any side effect to the embryo and is safe to be used in pregnancy. Other options were malathion, gabapentine hexachloride, and ivermectin. Talking about malathion, it is a category B drug, so it can also be prescribed, but it is not as safe as permethrin. Malathion is an organophosphate insecticide, and it acts as an acetylcholine esterase inhibitor in the nervous tissue. And coming to gamma benzene hexachloride, it is also category C, but it is an organochloride neurotoxin, so it has a very long life in adipose tissue. So how it acts is, it acts as a CNS stimulant, and it produces seizures and death in the scabies mite. But there are case reports suggesting that it can cause stillbirth infant, neural tube defect, and mental retardation after exposure to linden. It's another name. Now coming to an article published in Indian Journal of Dermatology in 2016, which shows that safety of topical medication for scabies and lice in pregnancy. According to this chart, it shows that permethrin is a category B drug. It is the safest one to be used, while others were not. Others belong to category C. Now coming to third question. Third question is middle-aged female with flaccid bulla all over the trunk and back, later presents with lesions on the mouth with painful swallowing. So patient is presenting middle-aged female with a flaccid bulla all over the trunk and back, and also there is oral mucosa involvement because she is having painful swallowing. Which of the following sign is most relatable to this disease condition? So we have option Auspitz sign, Nikolsky sign, Derrier sign, and Gotton sign. So as we know, Auspitz sign is seen in psoriasis, so this is not the answer, and Nikolsky sign is seen in pemphigus vulgaris, and the features suggestive of above question shows that this is a case of pemphigus vulgaris. So Nikolsky sign is the best answer, while the Derrier sign and Gotton sign are not seen in pemphigus. So We'll discuss further about the other ulcer also. Now first coming to Nikolsky sign. What is Nikolsky sign? Nikolsky sign, when we apply tangential pressure on a normal skin, usually we apply to a bony prominence area in the pretrivial skin, it results in formation of new bulla. So tangential pressure application on normal skin will produce bulla when we apply certain amount of pressure. So what is pemphigus? So pemphigus is characterized by cutaneous and mucosal blisters. Skin lesions in cutaneous blisters is flaccid bulla that develops on normal skin, and it ruptures in 2 to 3 days to leave painful erosion, and it has got tendency to spread and takes very long time to reepithelize. So this is a photo showing positive Nikolsky sign. Here we see that by dislodging the epidermis by lateral finger pressure in the vicinity of the skin lesion, that leads to erosion. So shearing stress on normal skin can cause new erosions to form. Now coming to Auspitz sign, as we have already discussed that it is seen in case of psoriasis. It describes pinpoint bleeding on the skin after dry scales are scraped away. Besides psoriasis, sometimes it can also be seen in other cases like actinic keratosis and diarrhea disease. How it occurs? It occurs when a small blood vessel underneath the skin ruptures, leading to small spot of blood. So we can see in the photo there is a very scaly lesion with the blood vessels prominent. This can be red in people with lighter skin, and they may appear purple or black in case of people with darker skin. Now coming to Derrier's sign. Derrier's sign is seen in case of cutaneous mastocytoma, and also it can be seen in juvenile xanthogranuloma and histiocytosis and lymphoma also. So what is Derrier's sign? It is refers to the urtication and edematous halo that are produced in response to rubbing or scratching of this lesion. So here in photo, this I have taken from an article published in ResearchGate. So Derrier's sign is an important dermatological finding, and it can be seen by stroking a mastocytosis skin lesion approximately 5 minutes with moderate pressure with a tongue spatula. So within a few minutes there will be wheal and flare reaction, and we can see the lesion has become bigger and it develops redness. Wheal and flare reaction can be seen in the lesion. Now coming to last sign, that is Gotton's sign. Gotton's sign is seen in case of dermatomyositis. It is also called Gotton's papule. It is a flat red rash over the back of the fingers, elbows, knees. So it is red, often scaly, bumps seen overlying the knuckles of the fingers, and it is symmetrically present in both the hands, and occasionally sometimes it is scaling, sometimes its appearance is violaceous red over the extensor surface of the metacarpophalangeal and interphalangeal joint. Their distribution is virtually diagnostic since it spares the phalanges. Phalanges is not involved in case of Gotton's sign, and it is seen in about 60 to 80% of patients of dermatomyositis. This is the case of dermatomyositis with Gotton's sign positive. Now fourth question, we come to fourth question, and the question says that at the bedside IV antibiotics are given to a patient without performing an antibiotic sensitivity testing. Within 5 minutes of antibiotic injection, patient developed pruritus with an acute urticarial rash. When we examined, the pulse was not palpable and blood pressure was not accessible. What is the most likely cause in this case? First option was normal response to drug. Second is anaphylaxis. Third is adverse drug reaction, and last one is fixed drug reaction. So this is not a normal response. By giving antibiotic, not every patient develops pruritus and acute urticarial rash. So most likely option is B, that is anaphylaxis. Now explaining anaphylaxis, as the patient was given antibiotic, and within 5 minutes of antibiotic injection without antibiotic sensitivity testing, patient developed pruritus, that is itching, with acute urticarial rash, that is red wheals all over the body, and when pulse was examined, pulse was not palpable and BP was also not assessed. So patient developed anaphylaxis to a antibiotic. So this is a life-threatening reaction that occurs within minute of systemic exposure to specific antigen and is manifested by respiratory distress, and that leads to laryngeal edema An intense bronchospasm also follows, that is followed by vascular collapse. So what are the cutaneous findings we can find in case of anaphylaxis? Patient will present with itching or pruritus and urticaria with or without angioedema. Besides these, other gastrointestinal manifestations are nausea, vomiting, crampy abdominal pain and diarrhea. So now we can see in the figure what are the signs of anaphylaxis. It can present with 80 to 90% features in the skin like urticaria, itching, swelling of lips, tongue, and in airway, the patient will present with tightness, swelling of chest, throat, trouble breathing, wheezing, and in case of CNS, patient will complain of headache, dizziness, anxiety, confusion, and in case of hearts, cardiovascular system, patient presents with chest pain, low blood pressure, and rapid heart rate. And in case of GIT, that is gastrointestinal tract, nausea, abdominal cramping, and vomiting with diarrhea will be present. So these are the signs of anaphylaxis. Now, other option was adverse drug reaction. So what is adverse drug reaction? Adverse drug reaction is the negative and undesirable effect of a drug. So in figure, we can see two types of adverse drug reaction. First one is exanthematous eruption, which consists mostly edematous macule and papule, that is seen in case of trunk area. And next photo we see toxic epidermal necrolysis. So in this case, there is peeling of the skin, there is purpuric macules with large skin detachment. So this toxic epidermal necrolysis is very severe one with a very significant mortality after toxic epidermal necrolysis, because there is systemic involvement as well as more than 90%, more than 30% skin involvement. Now last, coming to fixed drug eruption. So what is fixed drug eruption? It is a distinctive type of cutaneous drug reaction that characteristically occurs in the same location upon re-exposure to the offending drug. Like a patient will come to your OPD and present with a skin rash that is violaceous in appearance, dusky blue appearance. So when we take a history and we found that some offending drug is causing, and it occurs in the same site when the patient mistakenly takes the same drug second time. So what is fixed drug eruption? It is a delayed type of IV hypersensitivity, type 4 hypersensitivity reaction. So in the initial phase, there is a memory cell, CD8 T cells at the dermoepidermal junction, and that releases interferon gamma, which causes, when activated by the medication antigen, that causes epidermal basal layer damage, and that results in hypersensitivity reaction. So this is a case of a hypersensitivity reaction, that is delayed type of type 4 hypersensitivity reaction. So these are the photos I have taken from a site called DomNet NZ New Zealand. So first one shows a bluish dusky blue macule over the back between two scapulas, and second one is a targetoid fixed drug eruption, and third one is a blistering type of fixed drug eruption. These are the three varieties of fixed drug eruption. Now another question is, what is the treatment of choice for psoriasis on both elbows? So we have four options. First one is potent topical steroid, second is oral corticosteroid, third is cyclosporine, that is oral drug, and methotrexate, that is also an oral drug. So for this limited psoriasis, the most good option is potent topical steroid. Now explanation of why we are giving potent topical steroid. Treatment in psoriasis depends upon whether the case is localized, whether moderately extensive or extensive. So in localized case, when there is less than 10% body surface area involvement, we can give topical coal tar and short contact with the dry anthanol. So again, if there is no response with this medication, then in resistant cases we can give topical steroids and salicylic acid. But in clinical practice, we don't use the coal tar and diethanol so frequently, but topical steroid is most favored drug in case of psoriatic lesion. But in case of moderately extensive cases, that is more than 30%, 10 to 30% involvement, we give narrow band ultraviolet B therapy, that is phototherapy, or we can give PUVA A and PUVA Sol. So in extensive cases, more than 30% involvement only, we go for drugs like methotrexate and cyclosporine, and the methotrexate is first choice. And alternative, in resistant cases, we can try narrow band UVB Puvasol, or cyclosporin. So other option there was cyclosporin. So if it's a facial lesion, we can give topical low mid potent steroid, because in face there is chance of skin atrophy and skin redness, so we can give potent steroid in case of face. And for palmoplantar psoriasis, topical high potent steroid combined with salicylic acid under occlusion can be given. For palmoplantar psoriasis, if it's a very debilitating cases, it's not responding with any topical medication, we can give methotrexate. Now, why we should not give oral corticoid? Or among all those options, oral corticosteroid is not the favored option in any way. It is a wrong option. So the use of systemic steroid in the treatment of psoriasis can cause risk of disease deterioration after dose reduction or withdrawal. This can even lead to erythrodermic psoriasis. So oral corticosteroid is not the favored option among the three options. Now coming to methotrexate and cyclosporin. Methotrexate is an first line treatment for chronic plaque psoriasis. We can give once weekly oral dose in adult and children, but it can be given in pregnancy, lactation, severe hepatic impairment, severe renal impairment, and bone marrow suppression. As it is a teratogenic drug, it's absolutely contraindicated in pregnancy. So when we are giving it in a patient with female patient, we should always rule out whether she is pregnant or not. And we can also need, the patient requires oncological ongoing monitoring for hematological toxicity, hepatotoxicity, and infection. The other option is cyclosporin. Cyclosporin can be used in adult and children, but it is a second line drug because it can be used for rapid control of psoriasis. Like somebody is having a psoriatic patient is having marriage within few weeks, then we can give cyclosporin for a faster response, but it can be given for a long term without monitoring, because it has its own side effects, like it is nephrotoxic and it can cause hypertension. It can also be used for rapid control of psoriasis, palmoplantar pustulosis, and those contemplating conception, males and female, who cannot avoid any other systemic treatment. So it's safer, comparatively safer in pregnancy. Now question number 6 is, farmer walking on a field comes with severe itching and eczema all over the hand and feet. What is the most important cause of eczema in such a case? So as we all know, without walking on bare hands in a field can cause contact dermatitis, that is allergic type of contact dermatitis. So option among all the four options, walk on bare hand, use of gloves, use of topical steroid, and use of topical antibiotic. So these three are the protective ones, but you walk on bare hand can cause this type of eczema. So explanation for walk on bare hand. Walking on bare hand without gloves will expose the hand to different mud and different animal products in the field, so that this is the cause of allergic contact dermatitis, is mainly due to exposure to plant while walking on bare hand. Now, what is allergic contact dermatitis? It is a delayed type of hypersensitivity reaction mediated by memory T lymphocytes in the skin, and the eruption is linear or angular, and the sensitizing agent is urushiol. Now coming to last question, that is question number 7. A patient develops a single painless genital ulcer after 1 month of unprotected sex. The diagnosis is A. Canker, B. Cancroid, C. Donovanosis, and D. Herpes genitalis. So among the option, canker is seen in syphilis. Canker is seen in syphilis, and there is a history of single painless genital ulcer. Others option, there is some degree of pain, but in case of syphilis there is no pain. So this is a canker, and it is occurring after 1 month of unprotected sex. That means incubation period of syphilis is 9 to 90 days. Among other options, they have very short incubation period, but syphilis has a longer incubation period, and there is also history of 1 month of unprotected sex. So this is most likely answer among all is canker. So what is canker? Canker is a painless, punched out, indurated, raised border ulcer that is usually single, and the red smooth base is seen, and there is scant serous secretion. So this is in the photo, as we can see, this is a photo of a canker. Now explaining about what is canker. A patient is developing painless single genital ulcer after 1 month of unprotected sexual contact. So this is a case of canker. In 50% of patients with primary syphilis, typical lesion is present that is called canker. This is characterized by single painless regular indurated reddish or brown plaque that frequently ulcerates. Ulcer has a clean floor and it oozes clear serum on pressure. It without treatment also it heals spontaneously within 2 to 3 weeks, or on treatment with slightly atrophic scar. In the rest, ulcers are atypical, painful, multiple, or not indurated. In case of donovanosis and those cancroid, there is painful ulcer. Now, what is cancroid? Cancroid is caused by a fastidious gram-negative cocobacillus that is called Haemophilus duceri. So, what we see is there is acute painful genital ulcer that is associated with fluctuant lymphadenitis. We can see bubo formation in case of cancroid. So, photo here shows a case of cancroid, but it's not in the genital area, it's slightly in the inguinal area. Now, coming to donovanosis. Donovanosis is also a cause of genital ulceration, but it usually causes very beefy red color, and it is very painful and it bleeds on touch. And in case of last option, that was genital herpes is caused by a virus, that is herpes simplex virus, and they appear in blisters and they appear in and around the genital rectums or mouth, and the blisters, when they break, they leave a very painful sore that takes around weeks to heal, and the patient will also have a flu-like symptoms like fever, body ache, and swollen glands. Now, comparative in this chart, we are showing comparison between cancroid, donovanosis, and genital herpes. Incubation period is the shortest for cancroid, that is 3 to 7 days. Donovanosis is lasts from 1 to 360 days, and genital herpes simplex virus, that is 2 to 7 days. Ulcer, talking about ulcer, cancroid has a painful ulcer. Genital herpes is also painful. Donovanosis is also to some extent painful, but it is beefy red, and there is inguinal involvement. And how we diagnose is in the case of cancroid, culture or PCR of the ulcer base can be done. And in donovanosis, we can see donovan bodies on microscopy. And on genital herpes simplex virus, PCR or viral culture of the vesicular fluid, it can confirm the diagnosis. With this, we finish all the 7 questions of dermatology. Thank you.